Prospectus research presentation on the effects of a quality improvement program on the rate of blood culture contamination in the emergency department by Tracy Lutz. The purpose of the research study is to identify if a quality improvement intervention will impact the blood culture contamination rate. Approximately 1 million people are diagnosed with sepsis every year, and over half of these cases are fatal. Early identification of sepsis and septic shock is key for increasing a patient's chances of survival. A blood culture is the only microbiology test that will confirm what type of bacteria is present in a patient's bloodstream. This guides the physician's antibiotic selection and prevents antibiotic resistance. Contaminated blood cultures lead to an increased length of stay for patients in the hospital, which in return increases the healthcare costs. The national benchmark set by the College of American Pathologists is a contamination rate of less than 3%. There is not a specific benchmark set for the emergency department. However, the majority of the patients' treatment begins here. The research problem is contaminated blood culture occurs when normal skin flora is introduced into the collection containers. High turnover rates, poor techniques, and inadequate amount of blood collected have all been linked to a higher contamination rate. Patients are treated according to these positive culture results. Jean Piaget's theory of constructivism is the theoretical framework for this study. In constructivism, for an individual to survive in an environment, they must adapt to physical and mental stimuli. Time is critical when working in the emergency department. Tasks are often completed quickly to initiate treatment. This has resulted in an increase in contaminated blood cultures. One step in collecting blood cultures is to allow the chloroprep to dry completely. This process takes minutes, and often the staff do not wait for the full time for this to dry. Two concepts grounded in this theory is accommodation and assimilation. Accommodation causes an individual to incorporate new behaviors into their present environment. Assimilation causes individuals to develop new viewpoints, review what were once misinterpretations, and evaluate what is essential. Utilizing this theory for the development and understanding of new knowledge in the process of collecting blood cultures will help with the change in culture. Literature reviews were conducted on 4 different research studies. The first article reviewed was titled Reducing Blood Culture Contamination in the Emergency Department, an interrupted time series quality improvement study. For 5 months, the staff were observed to identify any areas for improvement. It was noted that a clean technique was used for collection of blood cultures in the emergency department. This study focused on a quality improvement intervention, sterile versus non-sterile approach for collecting a blood culture. The non-sterile approach was used as the baseline. During the baseline period, 321 cultures out of 7,389 were contaminated. That is a 4.3% contamination rate. In the study, the use of a sterile technique was applied in the emergency department for collecting blood cultures. During this intervention period, 111 blood cultures were contaminated out of 6,590. This led to a decrease in the contamination rate to 1.7%. In conclusion of this study, initiation of a sterile procedure, including sterile gloves, a sterile drape, chloroprep, a procedural checklist, all contributed to decreasing the blood culture contamination rate below the national benchmark at this facility. A noted strength was the support of the staff administration during this tedious process. A weakness was, in this research study, a literature review was not completed. This would help identify what measures have previously been proven to work. The second article critique was titled Reducing Blood Culture Contamination in Community Hospital Emergency Departments, Multi-Center Evaluation of a Quality Improvement Intervention. This study included 4 of the same researchers from the previous study. The study included the application of a sterile procedure for collecting blood cultures at 2 hospitals. Both are community hospitals, Hospital A had 35,000 annual visits with a contamination rate of 5%, and Hospital B was a smaller facility with 27,000 annual visits and a contamination rate of 2.5%. Both previously used a clean technique when collecting blood cultures. In conclusion of this study, Hospital A had a total reduction of 4.68% in blood culture contamination when compared with the baseline of 5%. Initially, Hospital B did not have a change in their contamination rate until a modification was applied. The sterile drape was removed from the process at this facility. A strength in the study was that it was a secondary study applied to original research, which increased the validity in the study. An identified weakness is the inability to determine the effects of each step in the sterile procedure. Knowing the effects of each step may eliminate any unnecessary time-consuming steps. The third article reviewed is titled Eliminating Blood Culture False Positives. Harnessing the Power of Shared Governance was a quality improvement project that focused on re-education and implementation of a skills checklist. The study reviewed retrospective data from 2010 to 2015 and determined a baseline contamination rate at this facility of 5.7%. A step-by-step checklist was created for staff to follow by the Shared Governance Committee. Re-education was completed to all the staff. A focus of the study was to maintain sustainability. A peer-to-peer review occurred whenever a blood culture contamination occurred. In conclusion, the new process resulted in a 70% improvement in the blood culture contamination rate, dropping it from 5.7% down to 1.7%. This facility also successfully met the national benchmark of less than 3% contamination rate, as well as an internal benchmark set by the hospital of 2.3% for 3 consecutive years. Maintaining compliance in this procedure by staff is a noted strength in the research study. A weakness identified was that the study did not identify what areas needed improvement in the collection of blood cultures. This would have been beneficial for further research. The last article reviewed was titled Reducing Blood Culture Contaminants in the Emergency Department, It Takes a Team, which was also a quality improvement study. A baseline contamination rate was identified of 4.3% at this facility. A multidisciplinary team worked on an educational tool and created a PowerPoint used for re-education of staff. Cleaning of the bedside table was a step added during the procedure in this research study. In conclusion, reduction in contamination from re-education was reduced to 1.96% contamination rate after the pilot study ended that lasted 8 weeks. A strength in the study was noted the identification of contaminated cultures that occurred in lab by personnel transferring the specimen into the Petri dish. A weakness identified in the study is the inability to apply this change to other emergency departments. The acuity of patients, size of the facility, and staff involved with the procedure varies from facility to facility. The independent variable in the study is re-education and creation of a skills verification checklist. The dependent variable is blood culture contamination rates. The research question that was identified is, in the emergency department, does a quality improvement intervention decrease the percentage of contaminated blood cultures in adult patients? An interrupted time series design was identified as appropriate research design for this study. The operational variable for this study is a decrease in the number of contaminated blood cultures. A common assumption in the ED is staff unintentionally eliminate steps in the procedure of collecting blood cultures to accomplish the task quickly and begin the treatment ordered by a physician. A limitation is a generalizability. Emergency departments are unique. They vary in size, skill of staff, number of annual visits, and cultures of the facility. What works for one facility may not be the appropriate intervention for the next. A delimitation in this study is that only data from blood cultures drawn in the ED will be included in the research study. Lab drawn on the units is performed by phlebotomists from the lab. They essentially have more time to complete the procedure. The research study will be conducted in a 42-bed emergency department with approximately 75,000 visits annually. Using a consecutive sampling method, all adult patients with blood cultures drawn in the emergency department will be included in the study regardless of acuity. Pediatric patients will be excluded from the study. Only one blood culture is typically collected on pediatric patients. Data will be collected from direct observation to identify what areas of re-education to focus on. A skills checklist with pictures will be created for staff to use as a resource. The laboratory will identify a culture as contaminated. An external review of the research plan will be conducted by the hospital's internal review board to ensure protection of human participants. A specific informed consent for participation in the study is not necessary due to the patients providing consent upon arrival to the ED for treatment. This study is not excluding patients from treatment. The participants' personal information will not be reported in the study, therefore privacy and confidentiality will be maintained. The percentage of contaminated blood cultures is attained by dividing the total number of blood cultures contaminated by the total number of blood cultures collected in the ED for the following periods. The baseline period, which is the pre-intervention, the intervention period, which is the educational period, and the post-intervention. A segmented regression analysis will be completed, revealing the percentage of contaminated blood cultures each month pre- and post-intervention. It is hypothesized that the graph will display a downward trend in the data collected to identify a decrease in contaminated blood cultures. In conclusion, contaminated blood cultures are a nationwide healthcare issue that determines the course of care for patients in a hospital. Appropriately evaluating the staff to ensure each step is carefully followed during the collection procedure validates compliance with the tool and change in nursing practice. Lowering the contamination rate to meet the standards also decreases healthcare costs and reduces cases of antibiotic resistance. Additional studies performed in hospitals mirroring the census and high acuity of patients in comparison to the research facility would be beneficial to identify the best evidence-based practice. In a fast-paced ED, it is essential to perform physician orders quickly to begin treatment and move patients through the department. Staff compliance with the quality improvement intervention should lead to a change in culture, thus improving patient outcomes and meeting hospital metrics.